Our next speaker is Dr. Johl, who is a medical oncologist, hematologist with Diablo Valley Oncology. Welcome, Dr. Johl.
Thank you. Thank you for the honor and privilege and the invitation to be here. I'll talk a little bit about what happens once you get the diagnosis, what happens after that once you've been diagnosed with cancer. So let me go through my slides. So just a brief overview of colorectal cancer. It's the second most common form of cancer diagnosed in men and women in the U.S. But interestingly, it was also on the radio the other day that the mortality or the risk for dying from colorectal cancer has declined, thanks in part to aggressive screening, a lot of the work done by gastroenterologists. And it was all over the news just a week or two ago. And the most important thing is finding this cancer early enough and getting it diagnosed, getting it treated, and hopefully, if all the cancers are diagnosed and treated this way, you would never have to see a medical oncologist ever, which would be the greatest thing for all of you. Then I won't have a job and I'll have to get trained in gastroenterology or something. Signs and symptoms, Dr. Johl covered some of this. I won't spend too much time talking about signs and symptoms with colorectal cancer. Again, the most important thing is looking for cancer even before you have symptoms through screening. By the time most people have symptoms from cancer and cancer gets diagnosed, usually we find it in advanced stages. So the key is to find it early before you have any problems. Diagnosing colorectal cancer, Dr. Johl did a wonderful job talking about colonoscopy, endoscopy, EGD to find cancers. There's a blood test called CEA. It's typically not used for screening. The reason is because there can be false positives and false negatives associated with this tumor marker. Once somebody has cancer, it's reasonable to check it and for follow-up, but it's not something we use to make a diagnosis. Colonoscopy is still the best way to diagnose polyps and finding colon cancer. Once cancer is diagnosed, yes, we do some other scans like a PET scan, MRI, and we'll talk about some of those in a minute, and ultrasound, to do what's called staging, to find out where else the cancer is located beyond the colon or the rectum. Some additional tests are done, and we'll cover this in a little bit more detail later, but once a cancer is diagnosed, we do certain analysis on the tumor specimen to find out if certain treatments will be right for the patients. One such test is called KRAS mutation, and I'll talk about that. It's a mutation in the DNA, and if present, can have important implications for the type of treatment you get. There's a test that's not commonly used, but ultimately will become more commonly used. It's called Oncotype DX, and it helps us for patients with certain stages of colon and rectal cancer, for example, stage 2, where we're trying to figure out if somebody should get chemotherapy or not. It can sometimes help us determine whether or not additional treatment is necessary. We don't commonly use this test for stage 1 or stage 3 or stage 4, but it may have some utility where we're kind of on the fence and in the gray area trying to figure out who should be treated with chemo or not. And something else we do, and it should be done on a regular basis at all hospitals, is once pathology is known, once diagnosis has been made, to test a tumor for what's called microsatellite instability. And at John Muir, we're doing this routinely for all the patients who are diagnosed, to see if there's any underlying genetic predisposition. If somebody has a genetic disorder like Lynch syndrome, that can be screened based on this test. And that has important implications not only for the patients, but also their family members to start screening earlier. So this is something we are doing routinely, and it's become a common practice. So let's say a screening colonoscopy is performed, a tumor is found. If it's a polyp, it's generally taken care of by the gastroenterologist. If it's something bigger, patient might see Dr. Uman. to get it removed. But let's say the cancer is a little bit more advanced. It needs further analysis. What we typically do at this point is via CAT scans, PET scans, ultrasound, MRI, and again, it depends, each situation is unique. We want to do what's called staging. Try to find out where exactly the cancer has spread to. And that involves, and this is something you see this commonly on the pathology report, the T stage, the N, and the M. The T and M staging system. That's a commonly used staging system. And it divides the cancer into four common stages, 1, 2, 3, and 4. And the treatment really is based upon what stage of cancer this is. If it's stage 1, sometimes it's taken care of, and many times can be taken care of by surgery. But if it's more, if the stage is 2, 3, or 4, it's treated differently, and I'm going to talk about that in a minute. But this is a commonly used staging system to find out the location of the cancer. And the T refers to how deep the tumor is invading into this wall of the colon or the rectum. Dr. Uman talked about different layers. So how deep the tumor goes determines what T is. N means lymph nodes, or any lymph nodes involved. And sometimes you can see that on the MRI, and sometimes we have to do a CAT scan or a PET scan to find out if any lymph nodes are involved. And very importantly, when surgery is done, the surgical specimen is analyzed, and in addition to looking at the tumor carefully, lymph nodes are also removed at the same time, and the pathologist goes through each and every single lymph node to see if they're involved or not. Generally speaking, we like to see at least 12 lymph nodes or more, which would be ideal, and more the better. If it's anything less than 12, you always wonder if there's any cancer left behind. So it's a common practice to look for as many lymph nodes as possible, and hopefully you see 12 or more to make sure we have enough confidence that the surgery was done appropriately and all the lymph nodes were taken out. And M stands for metastasis, and that's determined via scans. This is just a picture of what different T looks like, T stage, where it shows progression of cancer from T1 through T4. Again, that's not the stage. That just tells you the T part of the staging system. It tells you how deep the cancer is invading in different layers of the colon or the rectum. And it's kind of hard to see this from the back, but this is just for illustration purposes. So once a cancer is diagnosed, once we kind of go through the staging system, it's actually a team effort. I'm not the only person involved. We usually have a gastroenterologist who made the diagnosis. We have surgeons on the case. Radiation doctors are frequently part of the discussion because certain cancers like rectal cancer requires radiation. Most colon cancers don't, but if it's rectal cancer, radiation plays a role. And we, at John Muir and I'm sure other institutions, we do a tumor board. It's very important to get all the team together to discuss the case before you get started with treatment. I think that's important. Unless the tumor is a very early stage, let's say it's T1, and surgeon and Dr. Uman takes care of it. But in many cases, when the cancer is more advanced, it requires a team effort and a discussion in a multidisciplinary setting at tumor boards. This is where we discuss, hopefully every patient, but most of the patients, to come up with a treatment plan before we actually get started, because in certain cases like rectal cancer, you have to do things in a different sequence than you would in a colon cancer situation. So what are some of the treatments? Dr. Uman showed all the wonderful techniques in terms of surgery, and there are other surgical treatments that are offered. Other treatments that are performed include chemotherapy. Just a quick word, different terms are used for the chemotherapy given in different sequences. So if you give chemotherapy after surgery has been performed, we call it adjuvant chemotherapy. If you give chemotherapy or radiation or both before surgery is performed, that's called neoadjuvant therapy. And certainly if cancer is advanced, we give chemotherapy, we call it treatment for advanced cancer. And many times for rectal cancer especially, it's important that radiation is combined with chemotherapy to get best results before surgery is performed. And again, so surgery, radiation, chemotherapy, And all of these techniques are used in combination on different sequences to offer the best possible chance for a cure. And our targeted therapies, targeted drugs that are commonly used, especially in patients with advanced cancer, stage 4, rectal or colon cancer, these are some of the drugs I'll touch upon in a minute. And again, we always like to have patients participate in clinical trials if they're available in the local area. If not, we partner with various institutions nearby, Stanford, UCSF. So I'm going to briefly talk about colon cancer, how it's treated, and this will be followed by a brief discussion about rectal cancer. I won't have time to get into all the details of the chemotherapy, and we'll be happy to answer some questions. If it's early stage, stage 1, patients typically would see Dr. Uman and get surgery done, and most of the times patients do not require any further therapy. And many times they don't even see the medical oncologist. They get surveillance blood tests and colonoscopy by the gastroenterologist as well as the surgeons. Stage 2, usually if it's colon cancer, it's treated with surgery, which is for cure. And it's followed by chemotherapy in some cases, not all. And again, it depends on various factors, various tumor-related factors. And for high-risk patients, chemotherapy is offered on a selective basis. Not everybody needs to get chemo. Stage 3, it means the cancer is in the lymph nodes or gone beyond a certain depth in the colon. Typically, patients would get surgery, and this would be followed by, on average, 6 months of chemotherapy, which we'll talk about in a minute. But a common regimen that's used is called FOLFOX, which is a combination of drugs like oxaliplatin, 5-FU, and leucovorin. And that's a very standard regimen that's used across the country and even across the world. And for some patients, that may not be right for them. They may just get 5-FU and not the oxaliplatin. And stage 4, it means cancer has gone beyond the colon into other parts of the body, including liver, etc. In a situation like that, there are various different cocktails of chemotherapy involved, and that they're used by themselves or in combination with biological drugs like Avastin or Erbitux. We don't have to go through this slide, but basically this kind of breaks down into what percentage of patients fall into each stage. But as you can see, almost a quarter of the patients are found to have metastatic disease. The goal is to find the cancers early enough so patients can have surgery, which is the main form of cure for cancers, and chemotherapy is given to eradicate any microscopic cells in the local area or anywhere else. And radiation is used for rectal cancer to eliminate cancer cells in the rectum or the vicinity. This is a common regimen based on a landmark study out of France, the Mosaic trial. This has kind of led to a new standard of care for patients with stage 3 and some patients with stage 2. But this is a regimen that's commonly used for patients with metastatic cancer as well. It's called FOLFOX. Again, it stands for 5-FU, leucovorin, and oxaliplatin. And this was compared with 5-FU and leucovorin and was found to be superior, but it also has more side effects too. So it's not right for everybody, but we try to offer this to patients who can tolerate it. This is for adjuvant therapy, meaning if it's stage 3, cancer's gone with surgery, and then we have to give chemo. This is one of the regimens that's commonly used. The rectal cancer is different in the sense, based on its location. We use a team approach again. We try to discuss patients at our tumor board. Dr. Uman runs a tumor board at John Muir, and we have the privilege of working with him and a team of radiation doctors and medical oncologists. So we try to discuss how to manage these patients before they actually get started with treatment. And generally that involves looking at the scans, doing an MRI, ultrasound, which is done by the surgical team, try to find out exactly what the stage of the cancer is before proceeding with treatment. So this requires, the whole idea is to enhance patients' quality of life, sphincter preservation if possible, avoidance of long-term colostomy if possible, but then again, it requires a multidisciplinary approach, and each person is unique and different, each cancer is unique, and we have to discuss this in a tumor board setting to get the best outcome. As I mentioned before, surgery and radiation are chemotherapy and radiation are combined before surgery is performed. The type of surgery that is required is called TME. We don't have time to get into that. But the most important thing to remember is for surgery that requires expertise like rectal cancer surgery, it's very meticulous. It has to be done in a proper fashion. Not any surgeon can do this. Surgeons who are trained in performing a specific type of rectal surgery is we have the privilege of having Dr. Uman and his colleagues in this area, and we try to get them involved in any of our rectal cancer patients, because it's not, you have to develop expertise and you have to do a certain number of these to get good at it. So this requires a team approach. And the whole idea behind radiation is to prevent cancer from coming back in the rectum. And the whole idea behind chemotherapy is to eradicate cells not only in the rectum but also elsewhere in the body. These are some of the, let's say a patient has advanced cancer. The cancer has gone beyond the rectum or the colon and it's in different parts of the body. Then we're talking about somebody who has stage 4 cancer. And these are some of the regimens that I have listed here. And again, we don't have time to go through all of these. But the mainstay of chemotherapy are drugs that include 5-FU, oxaliplatin, and there's an oral drug called Xeloda, which gets converted into 5-FU in the liver. I haven't mentioned irinotecan, and also biological drugs such as Avastin, Erbitux, and Zaltrap. And they're usually combined with chemotherapy, and sometimes they're used by itself. Once the chemotherapy has achieved maximum response, the biological agents are continued for an extended period unless the cancer comes back. There's some new drugs that were approved recently, include Zaltrap and Stivarga, and they're biological drugs, but they do have potential side effects. And this is sometimes given after we've gone through the standard chemotherapy approaches. Again, we don't have time to go through this, but we also frequently use drugs called EGFR inhibitors like cetuximab and panitumumab like Vectibix, and again, in combination with chemotherapy, but also they can be used by itself at a later time. And we do a test called KRAS mutation on the tumor to see if somebody's eligible for some of these drugs, because if KRAS is mutated, if the gene is mutated, we can predict ahead of time that some of these drugs may not work. So then we don't offer these drugs and we go on to other potential drugs like bevacizumab or Avastin. Just because drugs are targeted and biological doesn't mean they don't have side effects. They all have unique potential side effects, and sometimes it's not easy to take some of these, but some patients can tolerate them fairly well. For example, bevacizumab is a drug commonly used for advanced colon cancer in combination or also by itself after a certain length of time, but it can cause significant elevation of blood pressure, perforation of bowel, and also stroke and heart attack. So just because the drug is biological and is not chemo does not mean it's risk-free. But if used properly, it can offer good control, but we have to watch for some of these other side effects. This is a drug made famous by Martha Stewart in secret stock trading. This is a drug called cetuximab. It's a monoclonal antibody that targets EGFR on the tumor cells. It can be combined with chemo. It works if the KRAS is tested and is found to be normal or non-mutated. But it also can have side effects like rash, skin rash. It looks like acne and diarrhea. And it can be synergistic when it's combined with chemo. I want to make a special mention. The patients who have stage 4 colon or rectal cancer with metastasis to the liver is a special situation. Most of the patients with stage 4 colon cancer ultimately will succumb to that illness. But patients who have cancer that's confined to the liver, even though it's stage 4, can have excellent control of cancer and potentially be cured, but that requires a team approach, chemotherapy, and also specialized liver surgeons who can operate and remove tumor from the liver after it's shrunk to a certain extent. At John Muir, Dr. Uman has done a wonderful job in working with liver surgeons from UCSF, and we have tumor board, liver tumor board, or called hepatic tumor boards, to discuss patients in these unique situations where patients may require additional treatment beyond surgery for the colon and chemotherapy, and we want to be able to offer additional treatment in terms of removing cancer from the liver. But then again, it depends on the size of the tumor, how many there are in the liver, so there's a lot of complicated discussions we have, and we meet every 4 weeks to discuss these unique situations. And studies have shown on this slide that up to a third of the patients can actually be long-term survivors if you use this approach. So this requires a special mention. And again, clinical trials are always ideal if one is offered. There's one offered in the community where we're looking at 3 months of chemotherapy instead of 6 months. It's a cooperative group trial, and time will tell if you can get away with 3 months of chemo instead of 6 for adjuvant therapy, meaning for stage 3 colon cancer, where patients are typically subjected to 6 months of chemo with FOLFOX, to see if they can get 3 months of treatment and still have the same outcome. We don't know, the study's ongoing, and highly encourage patients to participate in clinical trials if there's an opportunity.